Welcome yet to another episode of the NailedIt Ortho podcast. I myself am Dr. Cole. I'm one of your hosts, and I am also joined with...
Hey guys, it's the better half, Dr. Jamal Fitz. Nice to have you guys back with us today.
Man, whatever helps you sleep at night. We got a good episode today. We have Dr. Dixon. We're talking about Pilon fractures, so I think we should go ahead and just jump into it. Dr. Fitz kind of let us know a little bit more about our guest for the day.
Yeah, absolutely. Dr. Tanya Dixon will be our amazing guest that we have here for the talk today. We're going to be speaking again on Pilon fractures. Just a little bit about Dr. Dixon. She did her residency at the University of Cincinnati. She did her fellowship at Mass Gen in foot and ankle surgery, and she is now one of my favorite attendings. Look at that.
You didn't say that for brownie points, did you?
No. She's pretty nice with me and helped me out a whole lot. So, she gives me a little brownie points anyway, and I appreciate it. She's really awesome. So this talk is going to be great. Really enjoyed doing it. I think this is going to be great for not only medical students, but residents and even attendings maybe who want to look back and just go over some of the things they may have forgotten about Pilon fracture. So we're not going to spend too much time on this. I want you guys to go ahead and dive right into it. So with no further ado, enjoy the show, guys.
You are now listening to Nailed It, the Orthopedic Surgery Podcast, featuring Doctors Jay Fitz and Wendell Cole.
Dr. Dixon, welcome to the Nailed It podcast. We are happy to have you here and happy to speak to you.
Oh, thank you for having me.
Yes.
It's a pleasure to help you, gentlemen.
We love it. And kind of what we like to start off with and do is we kind of want to do like a one-liner, right? So when we go to the hospital, you might have a patient, you say, hey, this is a 34-year-old male that ground level fall X, Y, and Z, but we want to do it pretty much with ourselves, right? So mine, for example, would be I'm a 24-year-old male about to be an intern in orthopedic surgery. I love hanging out with my family, traveling, and doing fun sports. Or Dr. Fitz maybe
27-year-old entering intern into orthopedic surgery. Enjoy spending time with family and living life to the fullest.
So,
Gotcha.
What would yours be if you had a one-liner about yourself?
Well, I am a 39-year-old female who is just in her first year of practice as a foot and ankle surgeon at the University of Cincinnati. I enjoy hanging out with my family, which includes my husband and my 2-year-old daughter.
Love it. That was great. So what we kind of want to do is just ask you some general questions, kind of get to know you and kind of just see what your expertise would have or what your expertise would say. So a question I have for you is, what advice would you give to your 25-year-old self, if you could?
I think for me, it's always been, and I'm thinking of work, is, work hard, get the job done. I feel like the work ethic these days is not what it used to be, and so I think that's something that I admired in myself now and would encourage myself at 25 to continue doing.
That makes perfect sense. Sounds good to me. I think we have one more here for you, and this is something outside of work. We actually was going to ask, do you have any hobbies or interests outside of medicine?
I am a huge movie buff, so I really enjoy the theater. I actually recently just saw Hamilton in Chicago. So getting out to plays when I can, and then getting to the movies when I can. Obviously, with a 2-year-old, that limits what I can do, and that has definitely declined with her addition. But I wouldn't change it for the world.
Okay, I absolutely understand that, but I got to put this one out there for our listeners because this was a big one. Did you get a chance to see the Avengers?
No, I haven't. That is on my list to see.
Okay.
The last movie I saw was Black Panther.
Okay, well, you just put yourself back in there. There we go. We're good.
Oh, that's great. So, okay, great, awesome. So let's go ahead and jump into Pilon fractures. Pretty much what we're going to be talking about today, Pilon/Plafond. And what we'd like to do is we'd love to start out with a case and kind of go from there. So. Sure. Let's say we have our case here. We have a 50-year-old electrician brought to the emergency department after falling 10 feet from his ladder. shoes are still on, and he has an obvious deformity of his ankle. Can you kind of take us through what are some of the things that we kind of want to ask when we're taking our history, and what are some of the things that we want to be on the lookout for when we do our physical exams?
So obviously I'm jumping in right after, as a, orthopedic surgeon, is making sure that, everything else is fine with him, airway, breathing, that he's a stable individual, and then concentrating on, where his injury is. So obviously it's going to be his ankle. We know that there's a deformity. So the first thing we want to make sure is, does he have sensation? Is he able to move his foot? Does he have a pulse? That's probably one of the biggest things, because if he does not have a pulse, that means you need to get to a reduction sooner rather than later to restore his blood flow. Also, you want to look at what his soft tissues are. Like, is there an opening? Is it, grossly contaminated if it's open, meaning is there a lot of debris, grass, mud, that sort of thing, because that will determine how quickly you need to get him to the operating room.
And so once we've done our physical exam, what would kind of be the next step? What would you be doing next?
Next step, I would be getting x-rays to see exactly what I'm working with, what sort of fracture that I have on hand, and then once the x-rays are obtained, and if, say, there was an open wound, I'd clean it out preliminarily in the emergency room and then stabilize him with a splint, so both a posterior slab and a stirrup, to stabilize his fracture until his definitive or next step in care is to take place.
Okay. Yes, ma'am. And also, can we talk about, I know with these fractures, sometimes it might be a little tricky, but what is the actual technique that you would use for the reduction of this fracture?
That is a hard one, because these can be, sometimes not displaced or heavily comminuted, kind of a bag of bones, to where the best reduction maneuver is just pulling, axial traction and restoring his ankle out to length, and then depending on if he's going into varus or valgus, kind of controlling that deformity as well, while you're applying your splint. So there's not an exact, reduction maneuver per se, like you would say a distal radius.
Right. And kind of what I want to do is just rewind just a little bit and kind of go back into the radiographs. We mentioned that we would order x-rays. Can you kind of go on what x-rays, like what views we should order, and then kind of some of the things that we want to be on the lookout for with each view?
Sure. So you want to get your standard AP and lateral, at least. If you get an oblique, that's great, because that will give you, a different viewpoint of the joint. Each view gives you a little bit more information about the fracture and its comminution, etc. You also want to make sure that you get full-length tibia to make sure that there's not a proximal fracture, as well as knee. You always want to get the joint above and below. In this case, there's nothing below besides the foot. It is good to x-ray the foot, though, to ensure that there's no other talus, calcaneus, or even midfoot injury.
So say we have our patient and we've done our imaging, and we look and we see that, okay, this is a Pilon fracture. Can you kind of like walk us through kind of the mechanisms of how these Pilon fractures typically occur?
Sure. Pilon fractures are typically a high energy axial load injury. And depending on what position the foot is in, so if it's dorsiflex or plantar flex, you can get, comminution more anterior versus posterior as far as the plafond goes. And then there are the lower energy, not as comminuted Pilon fractures. Those are your, elderly population who sustain a fall, ground level fall, and unfortunately they have a Pilon.
Okay, perfect. That's actually, that hit right on the head for us. And let's see. So with these patients coming in with such a bad fracture and the comminution, sometimes is there often a use for CT scans with this type of injury as well?
Oh, absolutely. It just depends on when to obtain it. Most of the time with your higher energy injuries, you actually want to take them to the operating room. So if they have a open fracture, you're going to irrigate and debride, and then you're going to place them into an external fixator. This is a temporary fixation that will allow the soft tissues to calm down because this fracture, because the ankle is not forgiving with its soft tissue, that you have to allow the soft tissue to calm down. Sometimes it can be up to 3 weeks before you can fix them. Wow. So you want to get a CT scan after your external fixator has been applied so that you get a better understanding of your fracture fragments and your surgical planning. Sometimes for the lower energy falls, you don't necessarily have to X-fix them. You can get the CT scan at that time. And then, start your planning for surgery, or sometimes not if it's the case of, like, say, a poor elderly neuropathic diabetic, or just overall does not have good health, and non-ambulatory is another one that you may elect to treat non-operatively.
Right. So say we have this patient, and just like you just said, they have a high energy, they have a really big fall. They have a lot of axial compression coming in. And what are some of the other injuries that may be associated with somebody once we find out they have this Pilon fracture?
Oh, sure. They can have any fracture along that extremity. So a lot of times they have a calcaneus, talus fracture, sometimes midfoot injury. They can have a tibial plateau fracture, distal femur fracture, even femoral shafts I've seen, including pelvis, and sometimes spinal injury.
All right, that's perfect. So I'm gonna get back to the case. So let's say we've did the emergency, got them stabilized pretty much. We did the X-rays, we got in the CT. When we're looking at these images, in your opinion, is there any classifications that you use sometimes for these types of injuries?
For me personally, no. There are two classifications systems out there that classify these fractures. Obviously, you have your AO trauma classification, and then I can never pronounce this one. Rigatti Allgauer, I believe it is, classification. Those are just things that are out there, but typically, we don't use it to classify this fracture.
Okay. And yeah, I was kind of thinking, I was wondering, was there any good ones? Because I never did ever hear of anything being used all the time. So
no.
Okay. And
no, there isn't one where we often say, oh yeah, this is a for these. So it's not like, say, your calc fracture with the Sanders classification.
Now, I did have a question, because when we were reviewing, Pilon fractures, we saw that, a lot of it can happen from the axial compression, as well as the mechanism can be from shear forces. Like, how often do you see Pilon fractures resulting from shear forces?
It's not that common. I'd say most of the ones that I've seen have been more axial compression, but then again, I'm relatively new in my career, and I'm trying to recall the ones from residency, and I think it's mostly axial compression, but there are, those shear injuries out there.
Yes, ma'am. And also, so now, since we kind of hit on classifications, or the lack thereof, what would be some of the treatment options or the process you would go through as far as trying to decide what to do next for this particular patient?
That's a great question. So, after you've done your, temporizing with the X-Fix, you will assess your CT scan and, decide, okay, how am I going to treat this? Because you can treat this sometimes with an external fixator. Sometimes these are so badly comminuted that, or say the soft tissue injury is really bad, or if they're a bad diabetic or neuropath, but they need surgery, that sometimes treating them with a ringed fixator, so a little bit more complex than the external fixator, is one way to treat them. It decreases your risk of pin tract infections, not as much soft tissue dissection, and you can do percutaneous fixation if needed to stabilize the fracture. So, you sometimes will convert these from a uniplanar X-fix to a multiplanar X-fix once the soft tissues have calmed down and we get a better assessment with the CT scan. Most of the time, though, these are treated with open reduction internal fixation, and you will look at your CT scan to decide, all right, how am I going to need to fix this? Sometimes these are, a single-stage procedure. Sometimes these, have to be fixed from both the front and the back, depending how complex that is. So, you might be doing a posterior lateral approach, prone, and then flipping the patient and having to go either anterolateral or anteromedial, depending on your fracture fragments.
Okay. And yes, man, that was actually a very great explanation of everything. But if I could, I'm going to go back because I know always as a medical student, I know a lot of cases you would do the external fixation, but I never really learned all of the nuances behind it. And I know there are certain things you have to worry about. And I was just going to ask you, could you kind of say what's the purpose of that X-fix and also some of the things to look out for if it's like a 2-stage process and there's going to be a second surgery later?
Sure. So with the X-fix, the idea behind this is to keep the fracture out to length so that you're not shortened and having to struggle with obtaining your reduction. But it also, because you're maintaining the length of the fracture, it actually helps with the soft tissues to calm down as well. Ideally, you like to put this well outside your where your fixation is going to be. So you want to go pretty proximal on the tibia with your pins. And then, of course, you're going to be placing one in the calcaneus and most of the time one in the first metatarsal so that you're not putting the foot into an equinus position. And that helps keeps things, out to length and it prevents the Achilles from getting shortened.
Oh, okay. And just to recap, you said when you're typically doing an external fixation on these Pilon fractures, you typically put a pin through the calcaneus, a pin through the metatarsals, and you do a pin on the proximal tibia, correct? Typically two pins on the proximal tibia. You're doing what we call a delta frame or a triangle. Everybody has different terms for it, but it's just a type of fixation that we use just to stabilize the fracture. Now, what's the use? Because we were kind of reading up on some external fixators. So, what's the use of an external fixator that spans the ankle versus a external fixation that's kind of just applied to a single side?
So one that applies to a single side is ideally for like your tibial shaft fracture, femoral shaft fractures. You're obtaining length through one side, whereas for an ankle, you have to cross the ankle joint in order to pull it out to length. You're not going to be able to stabilize that fracture without crossing the ankle joint. So that's what you got to look at. Same with like a tibial plateau fracture. You're going to be placing pins in both your femur as well as your tibia to stabilize the plateau.
Now, if
that makes sense.
Yes, that does make sense. Yes, ma'am. Now, if we also had an associated fibular fracture in our patient that has the Pilon fracture, are we going to go ahead and put a plate on the fibula, or are we, like when we're doing the external fixation, will we go ahead and put a fibular plate on, or kind of how would you approach that? Would you do that in stage 2, or what would you do?
Great question. So if you are going to be the surgeon, this is my recommendation, and I know a lot of other surgeons' preference as well. If you're going to be the definitive surgeon, then yes, if you feel like getting the fibula out to length at the time of injury, and usually the fibula is forgiving, and you don't have to worry about the soft tissues, to go ahead and fix it. You can primarily at that point. If you are not, if you are just the on-call surgeon and temporizing, then, most of the time us surgeons would rather you just temporize with the X-fix, and then we can go back and decide whether or not to fix the fibula with the plate, because what you don't want to do is put an incision somewhere and then that affects the definitive fixation. So that might change how the fracture can be fixed.
And as far as the definitive fixation, what plates do you usually like to use for these types of cases? And I know it might be depends on the fracture, but I guess just if we can kind of get some scenarios and which ones you would use.
Yeah, that's a great question. There are obviously a variety of plates out there. I've used, just run-of-the-mill 1/3 tubular plates, in our small frag sets to, some heavy-duty distal locking plates. And it just depends on how much fixation you're going to need to, restore that articular block, because that's the idea behind a pilon fracture, is to get it back out to length, and then restore the articular cartilage, which is our plafond, and then ultimately connect that articular block or your metaphysis back to the diaphysis of the tibia. And so you need to make sure that your hardware is going to be able to accomplish that.
So if we're in a setting where we have a highly comminuted and highly displaced plafond fracture, what would your, I guess from there, kind of where would you go? Is like what would your thought process be as to, okay, how are we going to fix this highly comminuted displaced plafond fracture?
It's going to be based on my CT scan and where are my fracture fragments and how can I get to it? Because a lot of the times that these fractures have articular cartilage that has been pushed up into the diaphysis or the metaphysis, I shouldn't say diaphysis, metaphysis, mostly of the distal tibia. And so you have to be able to find a way to go in and get that. So that will dictate, one, where your approach is, and then two, being able to reduce that cartilage, which kind of plate am I going to be able to hold this together? Because that's your ultimate goal is, restoring that articular block so that, these patients are definitely going to get post-traumatic arthritis, and usually at a pretty fast rate. It's just you're trying to slow that down and give them relatively normal anatomy given their injury.
Yes, ma'am. And I think that's actually a perfect leadway to the next question. Can you tell us about some of the approaches that you would use during the surgery for these type injuries?
Sure. So there are, I think, 5 or 6 different approaches you can to the distal tibia. You have your straight anterior approach. This one isn't used a lot because it exposes your tibialis anterior tendon, and so you don't want to have any wound complications around that. But if you need to, a direct anterior approach to the ankle is utilized. You have your anterolateral approach, which you can go between usually your peroneus tertius and your fibula. Sometimes people go between their extensor tendons and the peroneus tertius. Usually, honestly, it depends on how the fracture has already dissected your anatomy for you. You have your anteromedial approach to the ankle, which is pretty much just going adjacent to the tibant. And then you have your direct medial approach. This is one that you just made right over the medial malleolus. Posterior lateral approach, which is probably one that I've utilized the most, where you go between your peroneals and your FHL. And then your posterior medial one is Usually you go between your FHL and your neurovascular bundle.
Okay. And just for completeness, can you kind of say which approaches you would choose if you have like a Volkmann fragment or a posterior lateral fragment versus anterior lateral fragment or Chaput fragment?
So if you had, let's start with the front. So if you had your anterolateral fragment, then you would, or your Chaput fragment, I would use the anterolateral approach. That is one way where you can, and most of the time, you're fixing these with an anterolateral approach. Sometimes anteromedial. We don't usually like to use anteromedial or medial if we can avoid it, because you have a higher incidence of wound breakdown, and you don't want to have hardware that's going to be subjected to that. So usually we'll try and go anterolateral to address that fragment, as well as to protect your hardware. For the Volkmann's fragment or the posterior lateral fragment, you'll use a posterior lateral approach. Of course, I mentioned that you're dissecting between your perineals and your FHL, and that just allows you to get down there, reduce that posterior plafond, and then, sometimes either it's plate and or screws to hold that fragment in place. And then if need to, you have to go and do another approach from either anteromedial, medial, or anterolateral.
I did have another question. So we went over the surgical treatments of, these Pilon fractures. Now, what are the non-surgical indications, the patients that we're not going to do surgery on that have these fractures?
Your non-operative patients are stable, fracture patterns where you don't have any articular displacement, usually, less than 2 millimeters or no displacement at all. Obviously, your patients are really ill who, undergoing surgery may be, cause them to lose their life, and family members may elect not to do that. You can treat them non-operatively, and obviously, as I stated earlier, you're non-ambulatory. You would not want to subject them to something that has a high risk for complications to have to undergo that. So you would treat them non-operatively.
Okay. Well, yes, ma'am. And just before we finish it out, a couple more questions. What are some of the? What do you usually tell your patient about rehab after an injury like this?
So with a Pilon fracture, I tell patients this is at least a year-long recovery process, and it's a life-changing. This is actually one where I tell them it's a life-changing injury because of the risk for infection, as well as post-traumatic arthritis, that this is going to change their life. And then I always tell them, you're going to be non-weight bearing for, at least 6 weeks, if not up to 3 months. And then from there, you start progressive weight bearing, and then walking with a boot, and then weaning out of the boot. So, it can be, 4 months or longer before you're in a shoe. Depending on which leg it is will dictate whether or not they're able to drive. Obviously, left-sided injury is better unless they have a manual car. Then they're not able to drive due to the clutch. If it's right side, they're not going to be driving for, at least 3 to 4 months. It all depends on when we allow them to start weight bearing. So if it's one where the fracture is not as comminuted, we might let them start weight bearing a little earlier, say around 6 weeks, and then they could be driving as soon as 9 to 10 week mark. They may not be out of their boot, or some surgeons won't let them drive while they're in the boot, and others will let them drive when they're walking in it, but walking in a boot, but take the boot off to drive, and then put the boot on when they get to their destination. Wow.
Yeah, that's great. Oh, I mean, not for the patient is not great, but I mean, your explanation of everything was great. I really appreciate you coming and talking about Pilon fractures and educating us on the different the different surgical management and pretty much all about Pilon fractures. Now, for the people listening that kind of want to reach you, and if they want to contact you or know more about you, how can they reach you?
Sure. Well, I am, as I stated earlier, I'm on staff at the University of Cincinnati. So my email address is tanya.dixon, which is Dixon @uc.edu. That's probably the best way to contact me, and I am open to any questions or comments about our discussion here today.
Well, thank you so much, Dr. Dixon. I feel very informed, and I'm sure our listeners are going to really enjoy this talk. So thank them for listening, and thank you even more for doing this talk for us.
Oh, it's my pleasure.
Okay.
Pilon fractures are complicated injuries.
Thank you all so much for listening to yet another episode of the NailedIt Ortho podcast, especially this episode with Dr. Dixon. I think she did a really great job giving us a great overview of Pilon fractures. If you like this episode, for show notes, go to NailedItOrtho.com and look up our episode with Dr. Dixon for Pilon fractures. It's a good thing to be able to look at those and kind of review those notes. It takes about 5 minutes. And while you're there, go ahead and subscribe to our page, subscribe to this podcast. Please give us a rating in the iTunes store and follow us on Instagram at NailedIt Ortho. Until next episode, guys and gals.